Good afternoon, everybody. Thank you so much for joining us today. My name is Matthew Rubin on behalf of the CPOP and MAPTA teams. Appreciate everybody taking the time out of their busy schedules to join us for the next 60 minutes as we discuss the role of access to medication-assisted treatment during the concurrent opioid abuse epidemic and the COVID-19 pandemic. We're really pleased to see such a robust turnout for this important dialogue, the second dialogue in a series of 4. Over the next 60 minutes, we'll focus on current efforts to improve access and availability of medication-assisted treatment, or MAT, to help address substance use disorders amid COVID-19. For more information at any point on the entire series, please visit www.cpoponline.org or reach out to myself, Matthew Rubin, again. A few housekeeping items here at the outset. For best viewing experience, we recommend closing any programs or browser sessions running in the background, since webinars are, of course, bandwidth intensive. Closing any unnecessary browser tabs will help to conserve your bandwidth. If you're experiencing any technical difficulties, please visit the webcast help guide by clicking the little question mark icon near the bottom of your screen or reference to technical tips. These resources should cover some of the common technical questions that might arise over the duration of the webinar. The webinar console you're viewing can certainly be customized. You can minimize, resize, or move any of the open windows at the bottom of the console or multiple application icons. If you have a question during the webinar, you can click on the Q&A icon to submit your question to the presenters. We'll try to answer these during the duration of the webcast, but if we run out of time, we'll certainly work to address your question via email. I also want to call to attention the resource list located on the left-hand side of your screen. There you can download a copy of the presentation slides and access additional resources. These will also be shared with all participants from today's call via email following this afternoon's webinar. We're pleased to be joined today by a longstanding CPOP leader who will help guide our discussion, Mr. Van Ingram. Van's the Executive Director for the Kentucky Office of Drug Control Policy. He joined this office in November of 2004, shortly after it was created, with the mission of coordinating Kentucky's substance abuse efforts in enforcement, treatment, prevention, and education. Prior to leading this team, Van served with the Maysville, Kentucky Police Department for more than 2 decades, the last 6 as Chief of Police. He's the former president of the Kentucky Associations of Chief of Police and was named Kentucky Chief of the Year in 2001. As many of you know, the state of Kentucky is one of the most comprehensive responses in the nation to the many challenges of the opioid epidemic. Even with all those responsibilities, Van has served as a CPOP steering committee member since the founding in 2014. Van, I can't state it enough, but we appreciate all of your work and your leadership, both with CPOP back home in the state of Kentucky and nationally. And with that, I'm really pleased to turn the webinar over to you.
Thank you, Matt. Thank you very much. And thank you to everybody who's on the line today. I know you're all busy, and I appreciate you taking the time to hear about this important topic, and a very timely one as well. We have an impressive group of speakers today on a critical topic. As you know, this is the second in a series of 4 webinars diving deep into the impacts and ongoing policy initiatives related to the confluence of the opioid epidemic and the COVID-19 pandemic. Many of these responses hit hard at the core of longstanding CPOP priorities. CPOP and MAPTA are partnering on this series to further important dialogue around preventing opioid abuse and overdose. A recent Washington Post article reported opioid-related overdose deaths have skyrocketed since the beginning of the pandemic. This comes on top of data released by the CDC showing that overdose rates increased again in 2019, following a short-lived decline in 2018. Both of these things are true to the Commonwealth of Kentucky as well. We've seen a very alarming increase in overdose deaths in April and May of this year. And we're starting to see a small decline, and I'm hopeful that will continue. CPOP was formed over 5 years ago to develop and advocate for balanced solutions in this crisis. With more than 80 participating organizations from all sectors, CPOP remains focused on this mission. MAPTA, or Mothers Against Prescription Drug Abuse, is a growing grassroots movement among families who have resolved to turn their experience into positive change with loved ones and across society. MAPTA is led by our CPOP co-convener and my good friend Mary Bono. Together, CPOP and MAPTA bring enormous reach and expertise to these challenges. It's now my pleasure to introduce today's first speaker, a longtime CPOP ally, United States Congressman Paul Tonko of New York's 20th Congressional District. He's joined us this morning to discuss ongoing efforts on Capitol Hill to address mental health and substance use disorders, especially given the impacts of the pandemic. Congressman Tonko is in his sixth term with the U.S. Congress, first being sworn into the House of Representatives in 2009. He serves on the Energy and Commerce Committee, which has oversight over many of the key issues that CPOP and MAPTA have as policy priorities. I want to welcome you, Congressman Tonko, and tell you on a personal note, I spent part of my vacation last year on Lake George. I believe that's in your district. And it was a beautiful area full of very, very nice people. We had a wonderful time in your district.
Well, so thank you, Van. That's good to hear. And it's good to join you. It's just north of my district, though, but we'll take credit for it. But thank you, Van, for your leadership and your kind introduction. And thank you, Matthew, also for the opportunity to join with you today. I believe Jeff Morgan is with us, our legislative director, who also does a lot of the work that addresses substance use and abuse and mental health issues and suicide prevention. So, Jeff, thank you for joining us and for being such a tremendous assistant in terms of developing policy and for leading us on our legislative team. Look, it's an honor to join with all of you. I know that these efforts come many times because of personal experience. So all of those who are part of the community that is fighting the illness of addiction, thank you for your inspiration, the courage that you show, the resilience and the determination are moving aspects that cause me to be deeply involved with all of you, and to all of the family and loved ones that surround those who take this very difficult walk in life. Thank you also for partnering in a way that expresses, again, a lot of courage. So thank you for our host, the Collaborative for Effective Prescription Opioid Policies and Mothers Against Prescription Drug Abuse. Your leadership, working through much of the pain that you've witnessed in your lives, is important in filling the voices of representatives here on the Hill in Washington and at state capitals across the country. I certainly appreciate the opportunity to share some thoughts and words with you this afternoon regarding my work to expand access to medication-assisted treatment and the confluence of COVID-19 with our existing addiction crisis that has really compounded the situation. We've heard some and seen some very staggering numbers that really express a sense of urgency that we need to apply to policy development and resource advocacy. It is indeed an honor to be with all of you. For those of you who don't know me, I represent the 20th Congressional District of New York. It's in the greater capital region of upstate New York, and if you were to draw a line from Boston to Chicago and Montreal to New York, I'm in the crosshairs. So that hopefully will place me on the map, at least for each of you. I currently serve as Vice Co-Chair of the Addiction Treatment and Recovery Caucus and as a member of the House Energy and Commerce Committee, where I've been at the epicenter of congressional efforts to respond to the opioid epidemic over the last few years. I've enjoyed that assignment. It's given us a lot of opportunity to dig deep into the policy that's needed and to advocate for that policy and not just put my name on legislation, but really fight to make certain that, that we do address with great sense of urgency and passion the issues that you understand to be of highest priority. Since coming to Congress, one of my top priorities has been improving care for those who struggle with mental illness or substance use as an issue. Certainly, the families and individuals have taught us of the need to be there when moments of clarity come. Services need to be provided. During my time working on this issue, Congress has taken some real positive steps to address the substance use epidemic. One that I note is the passage of CARA, and then the 21st Century Cures Act, and most recently the SUPPORT Act. While all of these bills moved us in the right direction, Congress has, in my opinion, not responded with the fullest and deepest measures of boldness that are needed to really turn the tide of the epidemic. Now, COVID-19 threatens to reverse even that minimal progress that we have made in slowing the rates of drug overdose deaths. Let me just dwell on that last point because I'm terrified by some of the data that we are starting to see when it comes to suspected overdoses during this pandemic, with what I see as a 42% year-over-year increase from May of 2019 to May of 2020. We have to reverse these trends, absolutely. We know that dislocation and social isolation are key risk factors for, for substance use. Despite the heroic efforts of those in the treatment and recovery communities during this time, we know that many will become disconnected from support systems that have helped them stay on the path of recovery. Economic downturns also have a way of exacerbating these diseases of despair. And so the impetus lies on us to set our nation on a path to economic recovery as quickly as possible. Now, more than ever, this disease of despair deserves a wholehearted response rooted in hope. One specific area where I think Congress could step in and provide some needed relief in this COVID environment is by increasing availability of treatment for those with an opioid use disorder. In that vein, we've carried legislation over the past 2 sessions of Congress that added new flexibilities around the current Data 2000 waiver system, which governs how and when providers may offer buprenorphine for the treatment of addiction. Our previous legislative efforts resulted in increasing the strict patient limits imposed on buprenorphine providers, as well as allowing NPs, PAs, and other APRNs to prescribe buprenorphine for the first time. Because of this legislation, and because of the increased efforts within the medical communities to have more providers obtain their waivers, we have seen thousands, literally thousands of new providers become waivered in the past couple of years, in theory adding hundreds of thousands of slots for treatment capacity. Everyone on this webinar should be proud of that order of progress. However, it is my fervent conviction that when 70,000 people are still dying every year of drug overdoses, and with numbers trending in the wrong direction again, that we simply have not done enough to address this issue. I have always believed that we need a no-barrier system of treatment on demand for individuals struggling with substance use disorder. Unfortunately, because of the waiver process, patients are often faced with a number of barriers before receiving care. This is particularly true in a COVID environment where many specialty substance use providers have had to reduce hours or shut their doors entirely, leaving patients with nowhere to turn. For an individual struggling with addiction, every potential door to recovery needs to be the right one, so that when they have that moment of clarity, we have a medical system ready to welcome them with open arms. Take, for example, a patient who presents at the ER with an overdose, but the ER doctor doesn't want to begin buprenorphine induction because they won't be able to send that patient with a take-home prescription that will last until they are able to see a specialist. Or take the patient who is in long-term recovery and stabilized on a steady dose of buprenorphine, but is still taking up a valuable treatment slot due to arcane bureaucratic rules. These patients and the treating providers would be better served by a healthcare system that by word and by deed really does treat addiction like other diseases, and not one that makes providers jump through special hoops for a single medication that is available without a waiver in other indications. The existing waiver requirement is simply a bureaucratic roadblock and adds no clinical value. The status quo is badly broken. If we had these kinds of barriers to care in other medical settings when 70,000 people were dying a year, trust me, I think you would agree, there would be riots in the streets. All of this is why I introduced the Bipartisan Mainstreaming Addiction Treatment Act. In brief, this legislation would eliminate the requirement to obtain a separate waiver for the prescription of buprenorphine for opioid use disorder, and would require HHS to conduct a national campaign to educate practitioners about the elimination of the separate registration requirement and encouraging providers to integrate substance use treatment into their practices. I fervently believe that if more providers across the healthcare system, especially primary care providers, can help take care of individuals struggling with this disease without having to navigate confusing and many times unnecessary regulatory barriers, we can make recovery a reality for so many more individuals. We have had a robust outpouring of support for our legislation in Congress thus far, with more than 100 bipartisan co-sponsors that truly span the political spectrum. We've got the head of the Congressional Progressive Caucus and the House Freedom Caucus on our bill. When's the last time you've heard of that combo for any legislation? In addition, top health officials from some 22 states and territories, both red and blue, sent a letter urging Congress to address this very issue, along with groups such as the American Medical Association and the National Association of Attorneys General. Given the urgent needs that this legislation addresses, I am indeed hopeful that we can still get this bill across the finish line this Congress, either as part of a COVID package or simply through another vehicle. Now, I've also heard some of the skeptics out there that are concerned that this legislation could increase illicit diversion of buprenorphine or lead to substandard care. I take these issues very seriously, but I would argue that this legislation will reduce the illicit diversion of buprenorphine by increasing the availability of legal addiction treatment. Numerous studies have shown that the primary reason for diverted buprenorphine is the failure to access legitimate forms of addiction treatment. Notably, the DEA itself has concluded in examining previous expansions of buprenorphine access that increasing access to buprenorphine treatment may be an effective response to the diversion of buprenorphine. By increasing the number of legitimate avenues through which individuals in need can get access and closing current treatment gaps in our system, we can reduce the self-medication that we know definitely is occurring on the streets today. In addition, I hear a lot about why we aren't addressing some of the other barriers to MAT that are out there, such as low reimbursement rates or prior authorization requirements. Let me tell you that I also agree that low reimbursement rates and onerous prior authorization requirements do in fact present significant barriers to patients in need of treatment, and we are supportive of any and all legislative efforts to address these barriers as well. However, just because other barriers exist shouldn't stop us from knocking down the ones right in front of us. One of my other big efforts to expand access to medication-assisted treatment is through my Medicaid Reentry Act. This legislation, as some or many of you might know, was generated in response to the overwhelming issue of substance use disorder amongst incarcerated populations and to improve continuity of care for these vulnerable populations. We know that people involved with the criminal justice system have a much higher prevalence of substance use disorder, with around 60% of individuals in jail or prison having a diagnosable substance use problem. We also know that with a few but growing number of exceptions, these individuals are not able to access the gold standard of addiction treatment behind bars. This lack of treatment is not only inhumane, it's illegal under the Americans with Disability Act, and it is helping to fuel the carnage we see across our country. We know that when these individuals are released untreated, they are 129 times more likely to die of an overdose in the first 2 weeks post-release compared to the general population. In states that have good data on this issue, we know that as many as 15% of overdose deaths can be attributed to individuals less than 1 year released from jail or prison. That could mean as many as 10,000 deaths annually from this population alone. This is a missed opportunity to give these individuals a fighting chance at rehabilitation and to be smart on crime at the same time. Government having a heart, government providing hope, government addressing all lives with significant integrity and dignity. Now, isn't that a great cause? The Medicaid Reentry Act, which I introduced and was included in the House Passed Heroes package, allows states to activate Medicaid coverage for individuals transitioning out of incarceration 30 days prior to release, which will help to finance care for COVID-related early releases while improving transitions to community care for those struggling with mental health and substance use disorder. I am thrilled this legislation is moving forward, and it's one of my top priorities to keep in our COVID response package that will be next offered for inclusion in what I hope is a bicameral, bipartisan effort. In closing, let me just say that if we want to truly address this crisis and save lives, we must be bold with our actions, and we must not fear shaking up the status quo. With that, I thank you for the opportunity to partner with you. I see you as agents of hope, and if we can deliver hope to the lives of so many across our country, I am flattered and honored to be part of that effort. So thank you for allowing me to work with you on that awesome mission, one that brings dignity to the equation in the lives of so many. God bless you all for the work you do.
Thank you, Congressman Tonko, for your remarks and for your continued efforts in helping to address mental health and substance use disorders faced by individuals in our country. We look forward to working with you from CPOP and MAPTA. We look forward to working with you in the future, sir.
Thank you, Van, and we look forward to that, and thank you. Your voices have filled our voice on the House floor, and we'll get this agenda done. I'm convinced.
Thank you very much. We're now going to turn from Capitol Hill to the Drug Enforcement Administration's Diversion Control Division. This afternoon, we'll hear from DEA leaders around the division's work to prevent, detect, and investigate the diversion of controlled pharmaceuticals and listed chemicals from legitimate sources while ensuring adequate and uninterrupted supplies of medications. During the national emergency, the Diversion Control Division is working across the federal enterprise with members of the White House Task Force, DEA registrants, and representatives of the healthcare sector to ensure adequate access and availability to prescription drugs for acute chronic pain and opioid use disorder. Joining us today from the DEA Liaison Section is Section Chief Claire Brennan, and from the Policy Section, Staff Coordinator Anastasia Martin. Ms. Brennan is the Chief of the Liaison Section for the Diversion Control Division. And in her current role, Ms. Brennan forges and maintains relationships between the division and the industry and other partners to communicate and educate on the Controlled Substances Act. Anastasia Martin is the staff coordinator assigned to the division's policy section, and she's responsible for aligning policy implementation with the Controlled Substances Act. Both Ms. Brennan and Ms. Martin are diversion investigators who have initiated, supervised many regulatory, civil, criminal, and administrative matters. Welcome to you both. We look forward to hearing from you. You got the floor.
Thank you very much. Good afternoon. This is Claire Brennan, and thank you for having DEA be able to be here with you today. I have as was said, Staff Coordinator Anastasia Martin with me here also. And we both work in DEA, the Diversion Control Division, and right now we're assigned to DEA headquarters in Virginia. The Diversion Control Division has been busy during this global pandemic, responding to public inquiries to ensure that there is enough continued access to necessary care, medications, and treatments. We're going to go through some of those shortly. First, I just want to take a little bit, you heard earlier, but I'll just reiterate a little bit. Our mission for the Diversion Control Division is to ensure that there's an adequate and uninterrupted supply of controlled substances and aggregate supplies for legitimate medical, commercial, and scientific needs. So in other words, we make sure there's enough supplies and medications for consumption, manufacturing, and research. We also work to make sure that there is, to investigate the diversion and detect diversion of illicit drugs for illicit purposes. And to do that, a lot of our responsibilities include schedules of controlled substances, set production quotas, establish import and export controls, investigate DEA registrants to detect diversion, conduct liaison with industries and associations representing registrants. We assist state and local authorities, represent the United States on matters related to controlled substances and regulated chemicals at the United Nations, and responsible for drafting and publishing regulations, which, as we're going to talk about more, became extremely important during the pandemic. With that, before we get into some of the exceptions of what we've published and drafted, we had back in November 2019, there was an executive order number 13891, which changed the way we have to go about actually changing regulations or updating them. So what happened was the executive order went into effect, and so that was just a few months before we started dealing with COVID-19. And this executive order now required all guidance documents be approved by both the Department of Justice and the White House Office of Management and Budget. Prior to that, DEA would publish documents on our own, even though we went through a rigorous process and it had to go through many different sections, so it still wasn't quick. We now went from having to go within one agency to go with 3 agencies. You can imagine the amount of time that it could take for those 3 agencies to sign off on a single guidance document. Sorry, I just lost that. I'm sorry, I lost, if someone can maybe change it. Not working for me right now. Apologize. I'm just going to continue. So some of the additions, so the other thing to remember, thank you. The other thing to remember is that with the executive order, DEA regulations can only be relaxed by or given exceptions by a triggering event. So in most cases, this would be the declaration of a public health emergency. So now we have our timeline of what happened with the COVID response. On January 27th, Secretary of Health and Human Services, Alex Azar, declared the novel coronavirus a public health threat. That distinction is important because at that time the classification was broad, did not meet the requirements to allow exceptions to DEA regulations and statutes. DEA immediately began to work with HHS to establish the parameters of the public health threat. And then a few days later, HHS added the necessary requirements to declare a nationwide public health emergency. And this now allowed DEA to make necessary changes to guidance and regulations with the use of certain medical products, including controlled substances, that falls within that emergency declaration. Another thing that's important to understand is that in order to make exceptions to regulations and issue further guidance, DEA must have requests from the public. So we just can't on our own sit there and say, this seems like a really good idea, we should make this exception. So whether it comes from the industry, manufacturer, distributor, or an association representing those industries, or other federal agencies such as SAMHSA, we need that request to come in. So between March 15th, after the public health emergency was declared, between March 15th and April 20th, DEA issued 24 emergency guidance documents to assist practitioners in treatment of patients. Next slide, please. So some of the ones that we did for medication-assisted treatment, what we also do is all of the exceptions were posted to our website, which is DEA Diversion website, but then there was a special COVID-19 page, so you could go to that page and get right to all these exceptions. So as soon as they came out, we were posting them. I was also with industry and associations. We were also getting these letters to them right away so that they could share. So we were not sitting on any information as soon as it was done. So some of these exceptions was doing the exemption allowing alternate delivery methods for treatment programs. This allowed that before that patients would have to come to the actual program. This allowed exceptions for take home and to be delivered right to the house. By the end of March, we provided flexibility to ensure patients the ability to receive medications by allowing practitioners the ability to prescribe methadone for OUD without requiring an in-person or telemedicine examination. And this assumes there's the ability to adequately evaluate the patient over the phone. So we were working closely with SAMHSA for all this, the use of telephone evaluations, use of unregistered off-site locations, again, that would be so that you did not have to get right to the treatment program. Distributor shipments to the program, signed delivery exception. This allowed for, just due to the fear of possibly signing anything, we gave an exception that you did not have to do it that day. And you had about 7 days to get the signed form back to the distributor. And then use of unregistered offsite locations then for buprenorphine. So on April 28th, we went back and made basically the same exception we had made with methadone for buprenorphine with the medication-assisted treatment. And these were done working, we were holding start daily to weekly calls with SAMHSA. So as soon as they would basically look or ask or make an exception, we would follow along and be able to get this through. Along with the medication-assisted treatment, to hit like the 24, we also had other guidance, and some of them were in the form of questions and answers. We had for prescriptions, registration, quotas, and the quota was bulk manufacturers controlled that they're the ones that make the controlled ingredient, so the actual, let's say, oxycodone. They were allowed to go over their normal 65%, which they have to stop at a point, but they were allowed to do that, so there were no shortages. We gave some questions, some electronic prescribing of controlled substances, just making some clarifications for hospitals so that everybody could keep on going. Again, with telemedicine, we made the exceptions, even for buprenorphine, that an in-person, we normally require one in-person visit before doctors or physicians or practitioners can go to other methods to see patients. We made an exception to that so that you could just do it with the use of the phone. And then just records and reports, we clarified some of that stuff for distributors and manufacturers. And these will all remain in effect until the designation of a public health emergency. As long as it's there, these will remain in effect. Another thing to stay up to date, so you can see here really quickly, if you can see the COVID-19 information page, that lists all the questions and answers and all the other guidance documents, and it's all broken down by prescriptions or medication-assisted treatment, so everything is very easy to find once you get to that page. In addition to that, we are continuing, I'd just like to, remind you about Take Back Day. Unfortunately, in April, this is another thing that my unit, we have oversight over. Unfortunately, in April, we had to postpone due to COVID. Our next Take Back is scheduled for October 24th. We're hoping to have it. Unfortunately, like anything else, we cannot make a prediction on that right now, but we are keeping it, as of today, we're saying it's scheduled until we can make a decision otherwise. TakeBackDay.dea.gov has a lot of important information. We also ran a Secure Your Meds campaign, just reminding people, in the meantime, if you have medications in your home, please secure them. that's continuous, whether you're done with the medication and you need to dispose of it, or if it's a brand new medication, we'd like to get that message out about keeping them secure, as I know all of you do too. And then also, if you go to this website, you can find where there's DEA registered collectors, and they're the ones that are open to the public to drop off, like pharmacies and some hospitals that have boxes where you can take your medications. And then also you can always contact your local police department, because many departments do have 24-hour collection boxes too. With that, I thank you for your time, and I just to remind you, we will continue to monitor the progression of the COVID-19 public health emergency. We'll continue to evaluate if additional guidance or exceptions to regulations are necessary. And I appreciate the opportunity to speak with you today.
Thank you very much, Claire and Anastasia, for joining us today. And we appreciate your agency's efforts to ensure a continuity of care during this pandemic. After hearing from Capitol Hill and the DEA, we're now pleased to have a panel of 3 national leaders to provide remarks on the clinical implications of the current pandemic on MAT access and utilization, as well as the impacts of ongoing policy changes to help address these challenges. Not surprisingly, traditional methods to access and engagement in care have been deeply impacted by the pandemic. We're now going to hear about several elements of healthcare delivery and policy that have evolved in this context. Each speaker will provide approximately 3 to 5 minutes of introductory remarks from their perspective, and then we'll have a facilitated dialogue and Q&A with the panel. We'll be saving all questions until after our presenters' remarks and the initial dialogue. And if at any point our viewers may submit questions to the panelists using the Q&A function on the left-hand side of the screen. We'll do our best to get to as many questions as possible and address the remainder in follow-up. First up, we're pleased to turn to a longtime CPOP participant, Shatterproof, and their Vice President of National Treatment Quality Initiatives, and my good friend, Sam Marshnaut. She's going to discuss the recent launch of their Atlas tool to facilitate entry into high-quality, evidence-based treatment. Sam is responsible for the development and implementation of the Shatterproof programmatic and research priorities with the addiction treatment sector, including Atlas. Prior to joining Shatterproof, she worked with substance abuse prevention and treatment initiatives in the Pew Charitable Trust. Sam, thanks for joining us today. The floor is yours.
Thank you so much, Van, and to the CPOP and MADPA teams for having me. For those of you less familiar with Shatterproof, we're a national nonprofit organization dedicated to reversing the addiction crisis in America. Since the early stages of the COVID-19 pandemic, we've seen a strain on addiction at all levels, exacerbating symptoms of people across the disease spectrum, whether it's hearing from a mom who is afraid because her son is increasing the intensity of substance use as a coping mechanism for having his life totally changed due to the pandemic, or straining access to relied upon services and supports for those in early and even long-term recovery, like one of our ambassadors who abruptly lost access to buprenorphine when his provider died and needed to find help quickly. There are also new barriers to accessing treatment for those seeking it for the first time, and a strain on family members, caregivers, and of course the provider community. We know what high-quality addiction treatment should look like in terms of patient-centered long-term care, but there is limited accountability and not enough support for providers to assimilate into this model, and very little transparent information for those impacted by addiction to navigate this space. During COVID-19, Shatterproof has continued to work to reduce the stigma around addiction and has been working to support universal education for healthcare providers on screening and treating substance use disorders, as described and championed by Congressman Tonko earlier in the webinar. Additionally, we've been working to address payment discrepancies in the addiction treatment space and to support expanded access to telehealth services, which I'm sure my colleagues will expand upon. But as Van mentioned, last Tuesday, we released a new resource that will help spur transformation in the addiction treatment system. Atlas, a quality measurement system for addiction treatment facilities, helps people identify the most appropriate type of treatment and locate facilities that deliver high quality care and creates a healthcare learning community for addiction treatment providers. I think everyone on this call will recognize that actually accessing evidence-based addiction treatment in the time of crisis in the first place can be hellishly complicated, but Atlas will make it easier, putting more people on the path to recovery. Atlas pairs an anonymous 13-question assessment that we developed in partnership with ASAM and OpenBeds to assess an individual's risk and severity on each of the 6 ASAM criteria and recommended treatment types. It then displays treatment facilities in our phase 1 states that meet that criteria. Atlas users can search and filter results with factors that are important to them, like insurance or access to medications for opioid use disorder treatment. The platform is now live in 6 states: Delaware, Louisiana, Massachusetts, North Carolina, New York, and West Virginia at treatmentatlas.org. But even if you aren't in those states, I'd encourage you to check it out. In the resources tab for this webinar, you'll find additional information on the multi-year iterative process that we undertook to identify the right measures to use in Atlas to assess the addiction treatment providers. The quality measures overview document is what includes this information, since it would take me a lot more than 5 minutes to summarize these processes. The data reveal that even among specialty addiction treatment facilities, there's tremendous opportunities for improvement in the use of best practices. For example, according to Medicaid claims data, the average provider organization has 35% of patients with an opioid use disorder receive medication, compared to the top 10% that has over 60% of their patients with an opioid use disorder get connected to this critical service. Using this information, we can start to set benchmarks and targets that will help accelerate improvements in care quality and make sure more people have access to evidence-based best practices. More findings from the underlying Atlas data like this are also included in the Atlas Analytics Summary document that's in the resources section as well, so please take a look at that. Overall, though, in addition to empowering patients and families to navigate the addiction treatment system at the individual level, Atlas enables payers and states to support changes such as paying for quality over quantity, or designing technical assistance interventions with a scalpel versus a sledgehammer. We're really excited about the possibilities here in partnering with our providers, payers, and state partners to continue to accelerate this change. Thanks for the opportunity to share.
Thank you, Sam. We appreciate your thoughts, and we appreciate Shatterproof and Gary and all the work that you all have done in a leadership role on this issue. Next on our agenda is Dr. Yuri Marijic, Chief Medical Officer at Pear Therapeutics. He leads the company's clinical, regulatory, and quality groups, and is the Chief Medical Officer and Head of Development. In that position, he manages all the development programs from discovery to market entry. Prior to joining Pear, he had similar responsibilities across several life sciences companies. He has pursued his education and training at Harvard, the University of Washington, University of Notre Dame, and the University of Virginia. Welcome, Yuri. We appreciate it, and we look forward to hearing your thoughts on Pear's role in helping to confront substance use disorder.
Thanks, Van. Really appreciate the introduction and the opportunity to be here. I think maybe just to highlight a couple points and share some experiences in the vein that Sam was just saying. So our work at Pear is really focused on trying to address 3 problems that we've just observed across in healthcare and public health, but particularly within patients suffering from addiction. And really the first is access to treatment. And this can be in many forms. It can be patients who aren't able to identify treatment providers. It can be geographic. But the other thing that we're seeing is also temporal treatment or limitations, particularly given COVID-19, which I'll mention a little bit more. The second is really a lack of effective treatments. When you think of the number of treatments that patients with diseases like cardiovascular or oncology have compared to the number of effective treatments in addiction, we really are struggling from a position of paucity. For example, until recently, patients with cocaine, cannabis, and stimulant use disorder didn't have any FDA-authorized treatment, and we see patients with opioid use disorder oftentimes go to places where they can only receive one of multiple types of treatment, and many patients stop using medication-assisted treatment, and we need to find ways to bolster patients continuing to remain in and engage with treatment. And then really the third problem is around improvements in outcomes and also the value of those outcomes. So improving the return on investment that the public health and also organizations who reimburse for care receive. And so our approach has really been at PAIR to bring software treatments that deliver evidence-based treatments to patients. And so we have two therapeutics. One is called Reset for patients with cocaine, cannabis, and stimulant use disorder, and our second is Reset-O, which is focused on patients with opioid use disorder, that were really developed in partnership with leading researchers, investigators, and also federal agencies like the National Institute on Drug Abuse. And these software treatments are able to deliver these evidence-based practices, particularly an addiction-specific form of cognitive behavioral therapy, fluency training, and contingency management, which many clinicians and clinical data support using but are difficult for patients to receive. And then we apply the same level of rigor that you would to any other type of medication. So all the software has to get manufactured according to good manufacturing practices and quality management system. They are then run through randomized clinical trials using the same endpoints you would for traditional medications. The data then gets submitted to the Food and Drug Administration and reviewed, and if they agree, the product is cleared with a label to treat disease. And then lastly, we work with insurance companies and CMS to ultimately achieve reimbursement for these therapeutics, because we really believe that we need to increase access, but also to make sure that there's strong clinical data, that just because it's software doesn't mean it gets the pass. And I think just lastly, in brief, what we're seeing in this era of COVID is that technology, particularly when you combine virtual technologies like telemedicine with traditional medications like MAT, and now opportunities like using prescription digital therapeutics, there's an opportunity to really meet patients where they're at so that you're improving outcomes, but you're also getting access and you're integrating care into new models of care, particularly hybrid and asynchronous. I think the second thing we're seeing is that you really have to integrate all treatment into the workflow and into the human element of care. While technology is critical, care is ultimately a human act and you can't replace it, and so you need to find ways to integrate and utilize technology within the broader confines. And then I think lastly is really focusing on value. So as we work with making sure that patients can get access, making sure that we standardize improvement in clinical outcomes, but also in terms of economic benefits so that we can really try and scale impact to patients. So I'll just pause there and looking forward to the additional discussion.
Thank you, Eric, for the remarks, and it's good to talk to you again. If people on the call are not familiar with Reset or Reset-O, I would encourage you to investigate it. I've learned a lot about it over the last year, and it's got a lot of promise. Finally, we'll hear from Dr. Mark Perino around the impact of the COVID-19 pandemic on opioid treatment programs. As president of the American Association for the Treatment of Opioid Dependence, Mr. Perino leads the association's policy and program initiatives. He's been involved with the delivery of health care and substance abuse treatment since 1974. Mark, we continue involvement in CPOP and welcome you for today's program. The floor is yours.
Well, Van, thanks for the introduction. It's a pleasure to be included in this program, especially with Sam and Yuri and Congressman Tonko and our colleagues from the DEA. I'll start with the fact that at the beginning of COVID-19 in mid-March, it can be safely described as a shock to our system, as well as the entire healthcare system in the country and the nation. To say the least, the initial response was difficult. OTPs, as outpatient treatment programs, were never set up for social distancing, given the number of patients that are treated in the opiate treatment programs on any given day. Additionally, we moved quickly and working with federal agencies, and I'm grateful for the DEA because they increased our ability to get access to immediate medication supplies and they did this within hours of a discussion, and with SAMHSA as well. I'm happy to say that up until recently, the patient infection rates were low. I believe this was a direct result of providing take-home medication on an emergency basis to a greater number of patients to keep them at home and coming into the program as infrequently as possible. That's worked. In the current low-impact states in the northeastern corridor, there has been a gradual return to pre-COVID-19 information and, in fact, in take-home medication. In the high-impact states at the present time, we are seeing patient infection rates rise. There was some staph infection, and that depended on the impact of state and the infection rates. I can also say that we had a terrible time in the first 7 weeks with getting personal protective gear for the staff and for patients, especially masks. It took a long time to work through. Fortunately, Assistant Secretary at SAMHSA, Dr. McCants-Katz, provided a letter on March the 25th, which provided an emergency exemption for the OTPs, basically characterizing the OTPs as essential medical services. This was followed by a letter from Jim Carroll, the director at ONDCP, to the entire treatment community, basically saying that we needed to have priority in accessing such equipment. We also issued guidance to the field on March 25th and April 23rd, and that's been part of the resource package here. I would say at the present time that we have been an adaptive response, that we have, in fact, created greater stability and working with our patients and other providers. In terms of expanding access to care during and after, I can tell you that first, we have been working with the DEA for the past several years. The DEA just announced and released its mobile methadone van guidance. They're working on it to refine it and publish it. They've been terrific to work with, and we think this is going to increase access to care, not only in urban environments, but in suburban and rural settings. To that end, we're working with the Department of Agriculture to get funding in order to purchase and expand access to vans in rural areas, especially given their requirements of a population of 50,000 or less. We're also going to work with criminal justice, especially corrections, in terms of increasing access to such vans dispatched from OTPs as hub treatment centers to the various correctional units. So basically, the vans can drive onto the compounds. We've been clearly working with a number of our partners in this process, including sheriffs, the American Correctional Association, and the National Commission on Correctional Health Care. With regard to increasing access to care through a greater footprint of OTPs, this includes developing more satellite medication units, which are currently not being fully utilized. So from our point of view, we're going to increase access to care, and I'm grateful to CMS Medicare also for creating the first Medicare reimbursement rate for OTPs treating Medicare-eligible patients, and that went into effect in January this year. We're now working with CMS Medicaid so that the 11 states that still need to provide Medicaid reimbursement for OTP patients, those who are Medicaid eligible, will get impacted and executed before the end of the current calendar year. All of these measures will increase access to care, whether it's Medicare reimbursement, Medicaid reimbursement, increasing access to care through the criminal justice system. And finally, one thing I'd have to say, we typically agree with Congressman Tonko because we think he's an incredible leader in Congress. And we understand his reasoning behind wanting to increase access to care by dismantling the Data 2000 program. We think the 8-hour online training is not a burden, and certainly training has increased by a factor of 400% in the last 2 years, according to the American Academy of Addiction Psychiatry. We can have a targeted response if there are Data 2000 practices that are overwhelmed or not able to treat patients. Certainly, you can work with the state opioid treatment authorities as a method of increasing access to care on an emergency basis. We do think it's critical to have clinical support services. And on one final note, SAMHSA has approved 80,000 plus practitioners in Data 2000. 50% are currently involved in active prescribing. So there are issues that need to be worked out. Aside from that, I'm grateful to CPAP once again for giving me this opportunity, for Matt and the other leadership at CPOP, and certainly to our associates throughout this field. It's been very helpful to have the support at the federal and state level, especially working with NASDAD and the state opiate treatment authorities. And so that's where I will conclude.
Thank you, Mark. And I know from speaking to some of our OTPs here in Kentucky recently, start was a little rocky, but things have smoothed out, and we've increased take-home doses, and that's all done very well. So thank you for your leadership with our OTPs. I want to throw this first question out to any and all of you. There are areas of the COVID-19 impact which are still continuing to thwart adequate care today. And I'll let any of you jump in.
This is Yuri. I'm happy to go. I mean, I would say really the main area that we are continuing to see challenges for patients is access. I think not being able to meet with providers and to receive effective treatments. And we're hearing from and speaking with many clinicians in different states where even when there's been particular efforts or initiatives on the federal level to streamline, for example, access to MAT or reimbursement mechanisms, that there are state barriers to that. And so we're really trying to see how we can help provide both those particular clinicians and provider organizations with additional ways to get access, and also loop them into efforts to remove any of particularly the state-specific barriers.
Thanks, Yuri. Sam or Mark, anything to add?
I think one issue that we're seeing is among folks that are relapsing and having overdose events because their tolerance has been reduced. Throughout that process, they're using the same dose that they were using before entering recovery, and it's kind of a symptom of a problem with what Yuri was describing that was happening even before COVID, which is limited access to medications for opioid use disorder. It's something that I think it's worth mentioning, that we're seeing the effects exacerbated of COVID-19 because that access was limited even before the pandemic.
I agree.
I would just say, this is Mark, that I think one of the greatest challenges to our system of care, and this has been clear, is the issue of stigma. You cannot underscore the importance that stigma has, even to this day, even with an opiate epidemic, even with the expanded use of prescription opioids. The reality is that a lot of Americans simply do not understand what medication-assisted treatment is for opioid use disorder. It's a major educational effort, and it's an educational effort that is long overdue, because people really need to understand that the people we serve are, in fact, individuals who suffer from a disorder, and they need treatment, and the treatment must be effective.
Thank you. Looking ahead at the next 6 to 12 months, what else is needed, especially if this pandemic continues to worsen, to ensure a continuity of care?
Well, from my point of view in representing the opiate treatment programs, we have gone into an adaptive response. I think that the challenge is now in high-impact states, but all the OTPs are essential services and remained open. There are some creative solutions, and I point to the 24/7 programs that were opened in Arizona by one of my more creative associates, Nick Stavros, and his staff, and this turned an OTP into a balanced version of an emergency room with immediate access to care, fanning out to other programs. So the continuity of care certainly is sustained by reimbursement. It's sustained by programs expanding their footprint. but it's also seen in the more innovative approaches and models of care.
Thank you, Mark. I hate to say it, there's a lot of brain power on this call. I wish we could go another hour, but our time is up. I want to thank all of our speakers who've joined us this afternoon to help us understand accessibility and availability of medications during this COVID-19 epidemic, or pandemic, excuse me. We hope you found the exchange useful as we consider the implications of the pandemic on serving individuals who struggle with SUD. Now, the recording of today's webinar will be made available to all registrants and posted both at the CPOP and MABDA websites. If you haven't done so, I'd encourage you to register for next August the 10th, when we'll hear from an equally impressive group of leaders on the impact of COVID-19 on access to controversial medications. If you have questions or follow-up on the webinar, please contact Matt Rubin. Once again, thanks for joining us today. We hope to see you on August the 10th. Everybody, have a good day. Have a good week.